All right, so I have my notes. Finally figured out how to do my notes on my iPad, so I might be looking away every once in a while. But as Dr. Carr said, I'm one of the fourth year residents. I went to UB for med school and I stayed here for residency. So I like to think that I'm an honorary Buffalonian. And today I will talk to you guys about HPV positive head and neck cancer. It's going to be a very general overview and just kind of an intro to the topic. I will try to keep it brief. This talk could probably be very, very long, but I'll try to do it in like 20 minutes. So unfortunately, I have no disclosures, maybe someday. Objectives for the talk, I'll briefly touch on epidemiology of head and neck cancer, specifically oropharyngeal cancer. We'll talk about different types of head and neck cancer subsites because they don't all act the same. We'll go over risk factors for head and neck cancer in general, and then specifically for HPV positive head and neck cancer. Very briefly, we'll touch on treatments, and then we'll go over prognosis, screening, and vaccination, as well as some of the vaccination guidelines for HPV. So what is head and neck cancer? When you hear head and neck cancer, it's technically every cancer in the head and neck. So it can include like skin cancers like melanoma that are on the head and neck, can be cancers in the neck like thyroid cancer. But for the most part, when we talk about head and neck cancer, the most common cancer is going to be squamous cell carcinoma, which is a cancer that usually involves mucosal surfaces in the head and neck. So we're mainly talking about oral cavity, larynx, nasal cavity, paranasal sinuses, those type of mucosal surfaces. And 4% of all cancers in the United States are head and neck cancers. So it is a significant amount. And something to remember is that head and neck cancers, I think that they're very unique from other cancers because they're extremely intimate, I guess. They can cause a lot of disfigurement in our patients. A lot of them need big surgical resections. A lot of them need radiation therapy, which can cause a lot of problems with speaking and swallowing. And these are all things that really make life really enjoyable, eating and talking. So a lot of these patients, you know, they're going through a lot during treatment and they can be very vulnerable. So it can be really privileging to kind of help them through that time of treatment. So what are our subsites? When we think of head and neck cancer, we're talking about, as I said, laryngeal and hypopharyngeal cancers. We're looking at nasal cavity and paranasal sinuses. We have our nasopharyngeal region, and then oral cavity, as well as oropharynx, which we'll go over in a minute. And then we have salivary glands. And salivary gland cancers are kind of their own thing. As I previously said, we're mostly talking about, when we talk about head and neck cancer, most common type is squamous cell carcinoma that is going to involve those first four sites listed there. And then other diseases or other cancers can be thyroid cancer. You know, eye cancer is in the head and neck, but we don't deal with eye cancer and ENT. Esophageal cancer, sarcomas, stuff like that. So this is just a brief overview of anatomy. If you remember correctly, we have our nasal cavity, which warms and humidifies air. And then behind the nasal cavity is the nasopharynx. Below that, posterior to the oral cavity, we have the oropharynx. And the hypopharynx is kind of this region around the larynx and posterior to the larynx up until the esophageal inlet. And today we're mainly going to be talking about the oropharynx. So why do I keep saying oropharynx? And that's because when we talk about HPV positive cancers, the most common site for HPV positive head and neck cancer is the oropharynx. And if you look here at this chart, you can see this is kind of a breakdown of HPV cancers based on subsites. So something that we hear about a lot. Can you guys see my cursor? I think so. Yes, okay. So cervical cancer is something that we hear about quite frequently, and that's listed here. But if you look over at oropharyngeal cancers, this number is a little bit old. It's actually higher than this now. You see that a large proportion of cancers are actually involve the oropharynx. And so these are going to be the tonsillar region, the base of tongue, and other oropharyngeal areas. Although you can have HPV positive cancers in the larynx and the oral cavity as listed in this chart here. They behave differently. And traditionally, as we continue this talk and as you think about HPV positive head and neck cancer, I want you to think of the oropharynx. And the way I like to think of it is you can have these HPV positive cancers, but they act differently based on the environment they're in. And so if you compare it to like a medical student, right? A medical student, same person, is going to act differently based on the environment they're in. So a medical student that's on their neurosurgery rotation is going to act entirely different than a medical student at a party after their first gross anatomy test. So very same person, totally different environment, behave totally different. So that's why it's important to remember that these cancers act different in the specific subsite of the oropharynx. And so what is the oropharynx? The oropharynx involves the posterior pharyngeal wall. Here on the right, you can see a cancer of the posterior pharyngeal wall. Soft palate is part of the oropharynx, tonsillar complex, and the base of tongue. Here you see a cancer involving the right tonsil. And this is a picture, I don't know if you can tell, but this patient has an HPV positive neck mass here. And that's just an important thing to mention because the most common presenting symptom of HPV positive oropharyngeal cancers is a neck mass. So frequently these patients do have metastases in the neck and they'll show up kind of looking like this. And then you'll do an exam and be like, where the heck's the cancer? And then you find the cancer because of the neck lesion. So when we look at all head and neck cancers, not just oropharynx, we can have the most common cause of the cancers and most common risk factors can be tobacco and alcohol. So tobacco increases your chance of head and neck cancer in general, not just oropharynx, by 10 times. Alcohol increases your risk by 5 times. And then if you use alcohol and tobacco, it increases to 35 times. So those are the most high-risk patients. And then when we look at HPV, HPV confers a 15-time risk factor for specifically oropharyngeal carcinoma. And other causes that we're not going to talk about, much smaller percent, the risk factor is much lower, but EBV virus and then betel nut chewing really increases the risk of buccal cancer and buccal mucosa. That is beyond the scope of this talk. So let's talk about risk factors for HPV positive cancer in general. So one of the major risk factors is male. Males have a male to female predominance is 4-to-1 for HPV positive oropharyngeal cancer. Increased number of sexual partners. So if you have greater than 4 sexual partners in your lifetime, then your risk goes up. Earlier onset of sexual activity, practicing orogenital sex, and males with a history of anogenital warts. So what I will find very interesting is to kind of compare oropharyngeal cancer to cervical cancer, just because as a medical student, you learn about cervical cancer, you learn about pap smears, you go on your rotations, and you're taught that at every primary care visit, you should be asking a female about her mammograms, her pap smears, her, all these female health factors. And, you learn about what are the pap smear guidelines, but nobody really talks about the oropharyngeal cancer. And as I said before, oropharyngeal cancer is rising and cervical cancer is declining. So it's a big topic. 95% of the oropharyngeal cancers are caused by the strain HPV strain 16, whereas the cervical cancers are caused by mainly strain 18. And the patients with HPV positive oropharyngeal cancer are quite different than the patients who have oropharyngeal cancer with no HPV. So those are cancers in the oropharynx that are caused by smoking and tobacco and not the virus. So patients with the virus causing the cancer are going to be younger with a median age of diagnosis of 54. They're going to have less exposure to tobacco and alcohol. They generally are of a higher socioeconomic class. They generally have higher education. And something that's important is they have better performance status because they're generally young and healthy. So they start their treatment much healthier than the population who gets cancer from alcohol and tobacco. And so they generally, for several reasons, they have improved overall outcomes. And as we mentioned before, the male to female ratio is 4:1. So we'll kind of briefly talk about the pathogenesis and how HPV causes cancer. So HPV causes these two proteins, E7 and E6, to bind to really important cell cycle checkpoints, or tumor suppressors and cell cycle checkpoint proteins. And so P53 is a tumor suppressor, and when E6 binds to P53, it causes the degradation, which then causes the loss of tumor suppression, and the cell can continue the life cycle even if it's damaged. E7 binds to retinoblastoma, which prevents a transcription factor called E2F from being produced. And so when it binds to retinoblastoma, this E2F causes transcription, causing the cell to pass from the G1 to the S phase, and causes uncontrolled cell proliferation. So it's really two areas that it's hitting, which then leads to carcinoma in situ and then eventually invasive carcinoma. Something important to note here, which I guess we'll touch on a little bit later, is that this transcription factor here is not regulated anymore, and so it causes an upregulation in the production of this protein here, which is P16. Frequently, when we are removing or excising cancers, we ask for P16 staining, and what that does is tells us if this protein is increased, this protein is high, then there's a high likelihood that there is HPV. We can also do specific testing for HPV, but it can be a little bit more expensive and difficult to obtain. So P16 kind of acts as a surrogate marker on these tumors to see if there is HPV causing the tumor. This is going to be very, very brief. So treatment really depends on the patient. That's the cool thing about head and neck cancer, is every patient is entirely different, and similar patients are going to need different treatment depending on if they have metastases in the neck, how big the tumor is, and how they respond to treatment, what you find during surgery. So sometimes you plan surgery and you figure out what treatment they need based on what the pathology after the surgery is. So they'll need surgery. Sometimes they can have definite radiation. Sometimes they need chemo and radiation. And sometimes they'll need surgery followed by post-operative radiation and or chemotherapy. And you can see here, these are PET scans on the screen here. This is showing a right oropharyngeal tumor with a metastases in the left neck. And here you can see the primary tumor in the right oropharynx with huge neck lymph nodes. So these patients, they both have, HPV oropharyngeal cancer, but they're probably going to need different treatments. So when we look at the prognosis, again, I like to compare this to cervical cancer just because cervical cancer is so popular in medical school to learn about that nobody cares about the oropharynx. So 5-year survival for cervical cancer is 67%. When you look at oral cavity and oropharynx, so kind of grouped together, it's 60%. So, it can be a devastating disease, and although HPV positive cancers have a better prognosis, it's something we should really learn about early on. So when you compare HPV positive to HPV negative oropharyngeal cancers, you see that the prognosis is much better when the patients have HPV. And this is because the tumors respond better to treatment. But it's also because these patients are usually younger, healthier, and generally they're non-smokers. You have to remember this is kind of the generation of people, people getting now are in their 50s, like mid 50s is the median age, where smoking was really discouraged during their lifetime. So the incidence of smoking in their age group is much lower. So they have a 28% reduced risk of death and 49% reduced risk of recurrence compared to patients who have oropharyngeal cancer caused by smoking and tobacco. And here on the right, we'll just briefly look at this, but this kind of looks at survival based on HPV status as well as smoking. You can see here at the top in green, these are patients who are HPV positive and are never smokers, and they have a really good 10-year survival. And if you compare that to the HPV negative smokers way down here in this red line, you compare their 10-year survivals, quite different. So as I said, different behaviors. So how about screening? We talk about cervical cancer screening, and that's because cervical cancer has very defined stages of development. It develops as a dysplasia, and then it progresses to carcinoma in situ, and then invasive cancer. And so we can pick it up along all these precursor stages before we get to this cancer stage. Unfortunately, with oropharyngeal cancer, acts differently than it does in the cervix, and we don't have these precursor lesions, so we can't follow them and catch them early. We can use P16 as a surrogate marker. You can do some swabs of the oral cavity to see if people have an HPV infection, but HPV infection does not predict the development of cancer. So it's not really a good screening tool when the majority of people who are positive for HPV in the mouth and oral pharynx will never develop cancer. So cervical pap smears work by sampling the mucosa, and they can determine kind of the dysplasia stage. So they can tell you if the patient has an early dysplasia versus severe dysplasia versus carcinoma in situ. What happens is the virus sneaks down into the basement membrane and infects at the level of the basement membrane. And then from there, it develops just into a dysplastic lesion. And so as I said, you can catch it along all these stages. But why can't we pap smear the tonsil? So the tonsil has all these big crypts and valleys. So if this here is the surface of the tonsil, this is just one little crypt that the tonsil has, and the tonsil has tons of these. And in these lesions, there's crypts, there's certain breaks in the basement membrane because of all the lymph tissue around the area. And it's very easy for the HPV virus to get into the basement membrane at these little breaks. And it kind of sneaks in here, and it can be all within this crypt. So if you try to sample one area up here, you're going to see something that's completely normal and miss something that's down here. And there's no progression to dysplasia. So we really can't test a precursor lesion. And that's why we do pap smear the tonsil. So what do we do? In 2018, oropharyngeal cancer surpassed cervical cancer when you look at cancers caused by HPV. So again, as I said, oropharyngeal cancer is on the rise, cervical cancer is declining. And so the question really is, can we do anything to prevent it? So we talk about the vaccine. The vaccine, there's 3 vaccines available for HPV. The only one available in the US, I believe, is the 9-valent vaccine, Gardasil 9, and it protects against all the high-risk strains. The strains that we mostly care about for the head and neck is 6, 11, 16, and 18. 16 and 18 are causing the majority of the oropharyngeal cancers. So we'll touch on the recommendations. They were just updated last year. So it used to be that patients age 11 through 26, the vaccine was recommended for. Multiple years ago, it was just recommended for females. They increased it to males. And now it's been increased for adults as well, ages 27 to 45. So it's recommended for all patients 9 through 26. In patients 27 to 45, it's approved, and the recommendation is it should be shared clinical decision making. If it's a patient with high-risk behaviors, such as multiple sexual partners, they would recommend that the patient get the vaccine. And then it's administered in different doses. So patients younger than 15 are going to get 2 doses. Patients older than 15 need 3 doses. And then all immunocompromised patients, regardless of age, should get 3 doses. And if we talk about the efficacy, so it has been shown to reduce the rate of infection and disease for cervical cancer in women. For oropharyngeal cancer, it's really hard to say anything because there's a 30-year latency from exposure to development of oropharyngeal cancer. So the people that are developing oropharyngeal cancer in their 50s probably developed the disease in their contracted the virus in their 20s. So we really don't know how this new generation who's receiving the vaccine, how it's going to affect the rates of oropharyngeal cancer. Hopefully, we hope that it reduces the prevalence of HPV 16-18 infection. If it reduces anogenital HPV, then it'll reduce transmission to the oral pharynx and hopefully reduce the rate of oropharyngeal cancer caused by HPV. So it's not predicted that oropharyngeal HPV positive cancer will decline until 2060. So in conclusion, when you think of HPV positive head and neck cancer, think of the oral pharynx. The prevalence of HPV positive cancer is rising, and it's more common than HPV positive cervical cancer. But an important thing to remember is the prognosis is better than HPV negative patients. So it's really important to get these patients seen, get them treated early, and they generally have really good outcomes compared to cancers caused by tobacco and alcohol. Unfortunately, we don't have any screening available, but we're recommending that patients get the vaccine in hopes that it decreases the disease prevalence, and we'll just kind of have to wait and see. So that being said, I think my final comments are to all the medical students that ENT is the best field ever, and you should definitely do it. It's super cool. Every time you're on call, it's annoying to get woken up at 3 o'clock in the morning, but sometimes you see the coolest things. This is a patient at the pediatric hospital who was working on, a 13-year-old working on a demolition derby car with his brother, and his brother backed into his head. You can see his skull showing there. Dr. Nagy, you might have been on call that night.
Probably.
And then this is a thyroid, a giant thyroid me and my chief resident, Adrian, took out last year. It was really fun. This is a spoon that was swallowed. This is one of Adrian's patients. I think he took it out in the ED, actually. And then over here, I can't see the picture all the way to my right because your guys' faces are covering it, but this is a picture of oropharyngeal resection. I think the patient was an HPV positive oropharyngeal cancer. And so you can see we've kind of opened the jaw here. We're reaching back into the oral pharynx to get the cancer out. Sorry if that grosses anybody out. And then I think another thing to remember is residency is really hard, but the people that are around you are really important, and the people can really make a difference. So we have a really great group of attendings here. We have a great group of residents here, and you're going to get good training wherever you go, and it's so stressful to apply to residency, but every program you're going to interview at, you will get good training at. Make sure that you like the people who are there. It's the people who are going to make all the difference in your experience. So does anybody have any questions?
Adrian, how'd you get that spoon out?
Yeah.
You just like reached in there?
It was a bad idea.
Your hand?
It was a Sweetheart, some midazolam, and I think I use a McGill's or a right angle or a tonsil or something.
Not allowed.
And you could kind of see it popping up like every once in a while when she'd open her mouth. It'd kind of pop up in the oropharynx.
So great. So cool.
There you go.
Yeah, shouldn't have done it. Should have done it. It turned out okay.
It's a good experience for you. Thank you, Ellen, for doing that. Does anyone have anything they want to ask her or mention, comment
I
on?
had a question. Yeah, so I was just wondering if there's any like current understanding to why HPV status affects the oropharynx versus the oral cavity or like the larynx?
They don't really know. They think could be something about the like lymph tissue around the region, and that for some reason the lymphoid tissue causes promotes the virus to progress into a dysplasia, but they don't really know why.
Okay, so HPV is more likely to be present in the oropharynx.
And if you have an HPV positive cancer that's like in the oral cavity, let's say on the tongue,
yeah,
those patients don't have better survival than oral cavity patients who don't have HPV.
okay, and it might.
So this like better prognosis, younger patients who get it, who do healthier, who respond better to treatment, that's only true in the oral cavity. Or I'm sorry, in the oral pharynx.
Okay, okay.
So it's not true for like larynx, even if they happen to have HPV positive larynx cancer, they don't have a better outcome than HPV negative larynx cancer.
Is it still tested in other sites, HPV status?
We do test it. I think most of the time we test it, but it doesn't really affect kind of the outcome, yeah.
Thank you.
Mm-hmm.
Anyone else want to make a comment? Question?
Yeah, I got a quick question. From that graph you showed earlier, it had like smokers who are HPV positive, smokers HPV negative. Interestingly, like smokers HPV negative did worse survival-wise. Does that suggest that being HPV positive and smoker being HPV positive like protective somehow for
No,
smokers?
it's just the smoking confers such a risk that,
Okay.
let me see, yeah, if I can go back, there it is. So
Yeah.
I think the blue is a never smoker and HPV negative. So, where's the, so you're kind of asking about the orange. This is HPV, sorry, can't see my screen now. Let's see if I can move it. Oh, I can move it. I can't move it. So it's not protective at all. It's just the smoking is such a risk factor that if they're a smoker, it decreases their survival, regardless of the HPV status.
Okay.